Hi, my name is Chris Boydis, and I am your instructor. In this lecture, we're going to cover the first chapter in your abnormal psychology textbook. So, a good place to start is, what is abnormal psychology? Well, abnormal psychology seeks to describe, to explain, to predict, and to control unusual behaviors. And we'll talk in just a little bit about what I call unusual behaviors. We use something called psychodiagnosis. And what this is an attempt to describe, assess, or draw inferences about psychological disorders. And we also use something called therapy, which is a systematic intervention, and it's aimed at modifying the client's behavioral, emotional, and/or cognitive state. So let's go into a little bit more detail about these things, and I think that they'll make sense to you. So as an abnormal psychologist, when we are diagnosing a person, we use a book called the DSM-5. That is the Diagnostic and Statistical Manual of Mental Disorders, and we're at the 5th edition. And here is a picture of what that book looks like. Any psychologist who's making diagnoses will have this book in their library. So, like I alluded to in the very beginning, just because somebody does something a little bit odd or strange doesn't mean that they have a disorder. The way we decide if somebody has a disorder is whether they meet certain criteria. And I want to go over what 4 of those criteria are. And this is a concept that we're going to use throughout the rest of the course. So it's really important to understand and to ask any questions if you don't understand this concept. So there are 4 Ds. The first one is discomfort. And if somebody has discomfort, it would be physical or psychological discomfort. Here is an example. A mother of 2, she's able to perform all of her roles. She is a mother, a wife, a coworker, a friend, and she does all of her jobs and she does them well. But if she's depressed, she very well could be terribly sad and feels like she has to force herself to do things. So we would say that this person is experiencing discomfort. She's able to do her job. You might not see it on the outside, but if you talk to her, she will tell you how uncomfortable she is. You'll often run into this with people that have anxiety, that they may be able to hide it and other people don't see it. But if you talk to them personally, it's causing great discomfort. So that's the first criteria that we're looking for. Does it cause discomfort to the person? The second D refers to deviance, and this would be bizarre or unusual behavior. And these behaviors, they're not accepted by society. A good example would be pedophilia. So let's say that we have a man and he becomes sexually aroused by flashing preteen girls. He may not be upset or bothered. He may not have personal distress over his disorder. However, society as a whole, we have determined that that behavior is not acceptable. It is deviant. So the first D that we talked about, the person was having personal distress. This one, it's not about distress. It is about whether or not the behavior of what the person's doing, if that is considered deviant. The third D refers to dysfunction. And dysfunction is actually the one that I look at first when I'm helping somebody come up with a diagnosis. Dysfunction refers to the inability or the loss of ability to perform one's normal roles. So if you have a normal role, let's say you're a parent and you have severe depression and you're not able to fulfill the role of parenting, you're not able to get out of bed, you're not able to prepare food for your children because you're so profoundly depressed, that falls under the dysfunction category. An example of this could be a man who has a phobia of bridges. Now, a lot of you may, and it's not uncommon, to have phobias of high places or phobias of bugs or snakes. And we use that term phobia in our everyday language. However, to meet the criteria of dysfunction, and this is so important, to meet this criteria, it can't be that you just don't like it. It has to go beyond that. It has to be to the point that it is causing some sort of dysfunction in your everyday life. So an example could be a man who has a phobia of bridges. He cannot apply for a job. His dream job is on the other side of the river, but he can't apply for it because he is terrified to drive across that bridge. That is getting in the way of his life. That is causing a dysfunction. Um, so if somebody says that they have a phobia of snakes, well, the question is, does it cause dysfunction in your life? Are there things that you're not able to do or roles in your life that you're not able to perform because of this phobia? And the last D refers to dangerousness. And this fourth criteria has recently been added, and we added it to try to predict whether or not a client is dangerous to him or herself. It is extremely difficult to accurately predict whether or not somebody's going to harm themselves or other people. If you have somebody that has harmed other people, almost always after the fact, the neighbors will say things like, yeah, he was weird, or I always thought he was going to hurt somebody. But we are not good at predicting that. However, the fourth D is dangerousness. And if you have somebody that, let's say they're fulfilling all their roles in society, we don't have deviance, but they are at the point that they're going to seriously harm themselves or they're harming others, well, that would fall into this dangerousness category. So we have the 4Ds. All you need is one of them to meet criteria, but you need to have one of them. So let's go over an example. So here's a disorder you may or may not have heard of. It's body dysmorphia. And with body dysmorphia, the person focuses on a perceived flaw in their body, and they think that other people notice it. Often people that have this disorder will have multiple surgeries to correct the perceived flaw. So let's say that I think that my nose is too big. And most people will look at my nose and say it's, sort of average. But I will think, if I have this disorder, I believe that my nose is too big. And I think that everyone else, like while you're listening to me, and you're probably right now, you probably are looking at my nose, but that everybody is like, all they can do is pay attention to my nose. Okay. So if I have that, I become preoccupied. Now, I am not diagnosing anyone or speaking ill of the dead. Let me just put that out there. I don't want to get the emails. However, one question that was always asked about Michael Jackson was if he had body dysmorphia, because he went, his face dramatically changed. It wasn't just plastic surgery changed, it was dramatically changed. So I certainly have no personal insight or knowledge. I have never met him. I do not know. But this could be an example of somebody who has multiple surgeries in order to correct something, when in fact, people would argue that it was okay from the very start. So I tell you all that because I'm going to use an example with my friend Heather. And right there's my daughter. Oh my goodness, probably 10 years ago. But my friend Heather. Well, Heather hates to wear sandals. And if you ever tell her I said this in class, I will deny. But she hates to wear sandals. And she hates to wear sandals because she thinks her toes are too long. When I look at her feet, they look completely normal. But she thinks her toes look long, and she will not wear anything open-toed. Ever. So the question I have for you is, does this meet criteria for a mental health diagnosis? Does she have body dysmorphic disorder? Well, to answer that question, let's take a look at the 4Ds. Is it deviant to not wear sandals? Does it cause her personal distress? Is it dysfunctional, or is it dangerous? So we have the 4Ds there: deviant, distress, dysfunctional, or dangerous. Okay, so let's go one by one. Is it deviant to not wear sandals? Now, has society deemed that it is unacceptable to not wear sandals? That's what deviant means. Well, society doesn't really care what you wear on your feet. You're not going to go to jail for wearing sandals or not. I personally refuse to wear spandex, but nobody, in fact, people are thankful that I'm not wearing spandex. So we all make fashion decisions, and even if it's something that people normally wouldn't do, society hasn't determined that that is horribly wrong or something that you should go to jail for or something that is morally corrupt. So it's not deviant to wear boots in the summer should you choose to hide your long toes, which, by the way, they're not long. Okay, so the next one is distress. Does it cause her personal distress? And sometimes students will argue that because Heather's uncomfortable or because she doesn't like the way her toes look, that she's experiencing distress. But keep in mind, when we're talking about distress, we're not talking about people. I mean, I get distressed when I look at the shape of my behind. But that is not stopping me from living my life and doing things. That's not getting in my way. So I wouldn't say that just because you don't like something or because you're mildly upset about it, that doesn't meet criteria for being distressed. So for it to be distressful or to meet this criteria, it has to be pretty big. It has to be causing, you have to be to the point that it is personally painful on an ongoing basis. Okay, so in this case, I would argue no. She might not like the way her toes look, but I wouldn't say that it causes her distress when we're making a diagnosis. Next one, is it dysfunctional? And dysfunctional would mean, does it cause her to not be able to fulfill one of her roles in life, like being a mother, a friend, an employee? So is there anything about what you wear that it would make it dysfunctional? Well, sure. Let's say that you had some sort of fetish and you were wearing things that would be deemed inappropriate. In fact, you would get fired for wearing to work. Well, then I would say it's dysfunctional. But in this case, it's not dysfunctional. It's okay if you wear sandals or if you don't. I mean, you can wear water shoes and it's okay. So there's nothing about this story that should lead you down the road to think that it's dysfunctional. So what's the point that I'm making through all this? Um, People are allowed to be weird. People can do weird things, but that doesn't mean that they have a diagnosis. That doesn't mean that they are what we would call mentally ill. People are allowed to be odd, they're allowed to be unique, they are allowed to do different things. And I say this very first lecture because I want you to understand that as we go through all these different disorders, um, it's important for you to keep an open mind and realize that there is a wide variety of things that are considered acceptable and okay that we would not say meet criteria for a mental disorder. So let's summarize this up. Heather would not meet criteria for mental disorder. To meet criteria, the symptoms would have to cause significant, I have that in caps and I'm yelling at you, significant problems, and it needs to meet certain criteria. And we'll learn about what that criteria is, and different disorders have different things that need to be present in order for the person to be diagnosed. So throughout this course, I'm going to give you some vignettes and I'm going to describe people. And sometimes they're not going to have a disorder. Sometimes people are just going to be odd, they're going to be unusual, they're going to be creative, or maybe they just have different beliefs than you do. That does not mean that they have a disorder. I want you always looking at the criteria, which you'll learn about, and then taking that criteria in an objective way and seeing if that person meets that criteria. The other thing that I want to mention is don't read into the disorders and assume that you have each one of them. I can't tell you how often it is when students go through this class and they read about disorder and they think, I have that. And then we get to the next chapter and they're like, that's me. So keep in mind that everyone experiences symptoms to some degree. So you're going to find things that may be similar. You may have experienced personally, or you may know somebody who has experienced them. But often what's important is how long it's been happening, the degree of severity, and also what else is going on, what other impairments or dysfunctions are going along with that. So please keep in mind that if you're reading something, you're like, that sounds like me, double check yourself. Um, because a lot of them, we've all experienced some of the symptoms. I mean, everyone in this class at some point has felt anxiety. Everyone has felt sadness, maybe to the point of depression. That doesn't mean that everyone has been diagnosed or should be diagnosed with an anxiety disorder or with major depression. So let's go over a few more vocabulary words that you're going to hear a lot in this class. First one is prevalence. And prevalence refers to the percentage of people in a population that have the disorder at a given time. So if I say the prevalence is 20%, that would mean in a general population, we would expect about 20% of people to have that disorder at that particular time. Lifetime prevalence. This is different. This has to do with the proportion of people in the population who have ever had the disorder. So if I say 40% have experienced major depression, that doesn't mean that right now, this minute, 40% of the people have major depression. If I said it was a lifetime prevalence, what that would mean is throughout their life, at some point, about 40% of people would experience the symptoms that we could diagnose them with major depression. The last one is incidence, and incidence is the onset or occurrence of a disorder over a period of time. So let's talk about how common disorders are. Some disorders are fairly common, and almost all of you will know somebody who has or will meet criteria for that disorder. There's other disorders that are less common. So, for example, when I say depression, anxiety disorders, addictions, they are much more common than disorders like schizophrenia or bipolar disorder. So, most common disorders, the phobias, drug and alcohol dependency, and depression. So just as a quick checkpoint review, we've talked about what abnormal behavior is. We talked a little bit about the criteria to determine normal and abnormal behaviors. We talked about the 4Ds. We did not talk about the difference between a psychologist and a psychiatrist. That is something I do want you to know. So let me just pause for a second and clarify that. A psychologist is somebody who often they have their master's or their PhD and they specialize in the treatment of mental health disorders. A psychiatrist is somebody who has their medical degree and then they go on and they specialize in abnormal behaviors. So the main difference between the two is somebody who is a psychiatrist, they have their medical degree. They went to pre-med and then they went to medical school. And then when they were done with medical school, they went on and they did a specialty in abnormal behaviors. The psychologists, they cannot write prescriptions, but they also have had a lot of training and expertise in helping people. Next one, which book do psychologists use to diagnose mental disorders? DSM-5 should come popping into your mind. And then how common are mental disorders? And I want you to have a general sense as to which disorders are the most common. I want to give you one last reminder to avoid diagnosing yourself or those in your life. Your loved ones will greatly appreciate if you do not start diagnosing them. And it is so tempting as we start going through these disorders, but please just keep in mind that a lot of the symptoms, a lot of people do have them, but it doesn't cause impairment. It's not dysfunctional. It doesn't cause great personal distress. It's not something that society deems as deviant. Okay, so when you're looking at the criteria, just avoid the temptation to overdiagnose. And be sure to read your textbook. I've only covered a few concepts in this lecture. So be sure that you also read your textbook, you do your Learn Smart material, um, and let me know if you have any questions. I welcome you to the class, and I am very excited to be working with you this semester.